Hello, everybody in podcast land. I'm Dr. Ted Thatchenkary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. This is a very special episode as we are featuring Dr. Jyothi Puthumana, who is professor of medicine and the director of Interventional Echocardiography at the Bluhm Cardiovascular Institute with Northwestern Medical Center in Chicago. Welcome to MD Roundtable, Dr. Puthumana.
Thank you very much, Ted. Thanks for this opportunity and for the ability to reach out to your audience. Thanks for this invite.
Of course. Yeah, my pleasure, Jyothi. Thank you for taking the time out to have you on, okay?
Yeah, thanks.
First off, Jyothi, why don't you tell us a bit about yourself? For example, where did you grow up?
I have kind of a long path. I grew up in India, in the southern part of India, in a state called Karnataka. And the closest town that most people are familiar with is Bangalore. So that town is about 4.5, 5 hours away from the small town. In fact, I grew up on a farm since my dad, for his livelihood, and he continues to live. He lives on a coffee plantation or a coffee farm. So that's where I grew up in the southern part of India.
That's great, Jyothi. Did you have to work the farm when you were a kid?
The location of where the farm is, there were no access to schools very close by. So we, in fact, it was me and 4 of my siblings. So we were 5 boys. The 5 of us and my mom lived in the closest town which had access to good schools, which was about 50 miles away. My dad lived on the farm, would kind of visit us on the weekends or the days when the people were off work at the farm. So we would spend our holidays and summers in the farm, kind of doing the supervisory role and in fact doing some of the work around what was needed to kind of run. As you can imagine, with any farm, it's a 24/7 enterprise. There's always things happening.
Sure. Very interesting. Who was your biggest childhood influence on becoming a doctor?
So you can imagine this is rural India, and with no clear access to medical care, and we are on this farm, and there are about at any time 25 to 35, 40 people who work on the farm who were living on the farm. So as you can imagine, these are people with very limited resources, with very poor diets, some amount of alcohol related abuse. So there was a lot of disease in this population and also infectious disease. So my father, who is not a trained physician, but was always inspired from one of his brothers who was a physician and kind of was always attracted to medicine, in fact, was the de facto, as you may call, like a country doctor for these workers on the farm. So I can remember from my very early childhood days, before I went to school, even when I was 2, 3 years old, I remember people who worked on the farm coming to the house asking for medicines for a stomach upset or a fever or a cold. And he always had a set of medicines. And as you can imagine, this is India and rural India, and TB was prevalent. There were a few of the workers and others who, at that time, it was injection of penicillin or streptomycin. And then still distinctly remember people coming once a week or so, where he would sterilize the syringes and needles and give them injections. So he was not a physician, but kind of I could see for people who could not travel 30, 40 miles, which in those days would take 3, 4 hours each way. He was kind of the country doctor who provided. So I think that probably, when I think back, is the person that I remember who was making an impact without being fully trained, but with the amount of knowledge that he had gained on his own, and from and was benefiting this very small community, but community with very little resources.
Yeah, that's very fascinating, Jyothi, that you were influenced by your farmer father who had no medical training This episode is brought to you by Cosmos by Echonos, which is an all-new category of ultrasound machine that is helping clinicians around the world transform patient care by making ultrasound imaging more accessible and easier to use. Echonos has packed advanced features and capabilities like auto ejection fraction, auto Doppler, auto preset, CW Doppler, and more into a device that's a fraction of the cost of your traditional cart-based systems. Whether you're a seasoned expert or just starting your ultrasound journey, Cosmos can grow with your practice, offering cart-level capabilities and a 5-year warranty. That's right, folks, a 5-year warranty without the cart-level price tag. Podcast listeners get a free premium feature upgrade. Choose from auto Doppler, enhanced cardiac calculations, and more. Visit echonos.com/podcast. That's ECHONOUS.com/podcast. Join thousands of clinicians who've already discovered the future of point-of-care ultrasound. Cosmos by Echonos, because better care shouldn't wait. And that was the person that influenced you. That's very fascinating. Thank you for sharing that.
Thanks.
So, continuing on your journey, Jyothi, where did you end up going to medical school?
So since we were in this town, again, I give a lot of credit and thanks to the Jesuits in India, the Jesuits have been present in India for 400 years or so, but they've had a significant impact in early and mid-level education. So we were lucky that the town we were in had a very good Jesuit high school. So we went to this school, and followed by going to a college that was about 100 miles away in a place called Mangalore, which was again a Jesuit college, which is where we did our pre-medical college education. And then it so happened that, but again, the Catholic Church in India has had a big impact from an education and healthcare perspective. So there is a medical school in Bangalore, which was established in 1960 by the Catholic Bishops' Conference of India. So it's a Catholic medical school set up by the Bishops' Conference called St. John's Medical College. Very interesting, the whole philosophy of the college. If you look at the philosophy, it says, "He shall live because of me." And that was kind of the essential charism of what the school was set up on. The goal of the school was to train 60 young adults to essentially gain the skills to be able to take care of people who had very little access to medical care. So I was kind of lucky. I don't think I was they had an entrance exam, and I was kind of, I would say, more lucky than smart to be able to get into this medical school. It was at a very crucial time of, as with all of us, we are 19, 20, kind of a very formative part of my life was spent at this medical school. So I kind of give a lot of my thinking and my success, I owe it to them.
That's very impressive, Jyothi. So you did your medical school at St. John's in Bangalore, and then how did you end up in the US? And where did you end up?
So it was kind of prudential and coincidental that we had this opportunity as a family to immigrate to the US. Again, thanks to the immigration system in the US that was set up, and thanks to an uncle of ours, my dad's youngest brother, who had moved to the US in the 1960s and was working as an engineer for the EPA in New York. And he was kind of had a lot of foresight to suggest to all his siblings that he would take the initiative to apply on behalf of all of his siblings to be able to immigrate to the US, and not with the goal that his siblings would work here, but with the opportunity that their children could have to have lives and livelihoods and careers in the US. So a lot of credit to this uncle of mine. And it coincided nicely that when I was finishing medical school, all the paperwork that allowed me to immigrate to the US happened. So I was able to kind of, with maybe a year's break where I did work around in Bangalore, but with a year's break, I was able to kind of come to the US. I had finished all my USMLE exams, and I was able to start training. And my first location of where I did my residency and the early part of my training was in Detroit, in Michigan.
Ah, okay. Where in Detroit, Jyothi?
So I was at the Wayne State University Medical School, which has two or three hospitals. The two main hospitals that I did my training out of was Detroit Receiving Hospital and Harper Hospital, and then they had a couple of other hospitals called Grace Hospital and so forth. So this is in the middle of downtown Detroit, and this is where I did my internal medicine training.
Great, great. And what made you become interested in going into cardiology?
I think there was even before so the gap year that I had after I finished medical school and internship in India, the Indian medical system makes you do a 1 year mandatory rotating internship through all the specialties. So I had spent a little bit of time in cardiology. Then I had a gap year before my papers were going to get ready. So then I had worked in the CCU as a house officer back in Bangalore at St. John's Medical College. So I had been exposed to these amazing clinicians who were mostly making diagnoses based on kind of hearing the patient's story, listening to them by stethoscope, very rarely doing echocardiograms, and again with dealing with patients who really had. It is all pay for care in India. So these were patients who had limited resources. You're seeing a lot of rheumatic valve disease. This is in the 1980s, so there is not a lot of premature coronary artery disease as yet in India. And then, so there was a good amount of valve disease and so forth. So, through my residency training, I was always already had, I think, a seed of interest in cardiology. So, I was always looking to these rotations, whether it was a consult service or other elective rotations. And then, so there were some very impressive clinical cardiologists at Wayne State, many of who had moved from the Brigham and Women's to establish a cardiology division. So these were all leaders in the field at that time. And I think it was a continuation of an interest that I had built that kind of was further flamed by working with these faculty members.
That's brilliant, Jyoti. And did you know even back then that you wanted to do more of a non-invasive cardiology field?
Not really. So that is an interesting path that happened. As with most cardiology fellows in their first year, what is very attractive is the ability to do procedures. They say cardiologists are frustrated surgeons, meaning that if they want to do procedures, but then they feel that either they don't have it in them to do 5 years of training, or they would rather not have to deal with all the post-operative related recovery issues. So anyway, the cardiology fellows in the first year are always attracted to procedures, mainly angiograms, angioplasties. So it's always a new skill that was completely. So that was kind of what I was leaning toward in my first year of cardiology fellowship. And purely by coincidence, I was in my second year of cardiology fellowship, and one of my mentors, who was an outstanding clinical cardiologist, told me, I think before you really decide on, why don't you go and do this 1 year of preventive cardiology fellowship at the Brigham and Women's in Boston? It will give you kind of like a Boston part to your resume, and then also will be completely different from what your focus now is. And you'll have an exposure to epidemiology. So you will kind of really, at the end of it, be able to figure out if you are truly kind of interested in interventional versus epidemiology. So that took me from Detroit to Boston to pursue a preventive cardiology fellowship with some of the leaders in the field. And after spending a year working on these large databases and in a preventive cardiology setting, I realized that I was not set to sit at a desk and be analyzing databases and get all my satisfaction from writing grants or papers. And so then I was able to find a couple of non-invasive cardiologists in New York who kind of were inspiring and showed this pathway of using this to achieve both the clinical and research objectives that I had in mind. So with that, I switched over to doing a non-invasive fellowship And for that, I moved to New York. So this was the Columbia University hospital at that time called St. Luke's Roosevelt, and they had a 1 year fellowship in echocardiography, nuclear cardiology. So that was my additional year of training, and that I was kind of fortunate. Looking back, which is now 20 years back, looking back, I'm kind of glad that my trajectory took me to what I've continued to enjoy since.
Great. Very impressive, Jyothi. It looks like that year in Boston really solidified your path.
Yeah, I'm glad for that year. I was kind of at that point, like they say, with everything, good luck, bad luck, who knows. I was very frustrated with that year because I was frustrated that I could hardly be productive. And I was like, I'm wasting a year without getting clinical experience. And some of your audience may know when you're working with these large databases, any request takes a couple of months to turn around. So a year is actually very little in terms of the amount of time for you to get anything significant or productive. So it was indeed a frustrating year, but looking back was a very important year that clearly gave me a pathway to what I should do in cardiology specifically, and kind of has since directed my kind of career path.
Great. Thank you for sharing that, Jyothi, regarding your journey. So now let's get to the medical portion of the talk, Jyothi. I think it would be very beneficial to discuss mitral regurgitation, or MR, for our listeners. Jyothi, can you tell the audience what MR, or mitral regurgitation, is and what are the causes of it?
Mitral regurgitation. So mitral valve is the valve that is between the left atrium and the left ventricle, which are the left-sided chambers of the heart, which then pump blood to the rest of the body and help to maintain our oxygen levels and so forth. So the mitral valve is a valve between the left atrium, which is a lower pressure chamber, and the left ventricle, which is a higher pressure chamber, the same pressure as our blood pressure. So this valve is a very interesting valve, and mitre kind of means the hat of a bishop. So kind of the mitral valve is shaped like a bishop's hat. There are two leaflets. The anterior leaflet is almost like a curtain, which forms bulk of the leaflet, and the posterior leaflet, very interestingly, the way our creator or made us, is divided into three specific pieces to decrease the amount of tension, and kind of the tension is dispersed between those three pieces. So we call them scallops. So this is the mitral valve that is present in all of us. And some of you may have heard of mitral valve prolapse, which was a clinical diagnosis that your physician or cardiologist would tell you based on hearing a click when they listen to your heart, and a murmur, which was when the valve does not fully close and the blood leaks backwards instead of being pumped forwards. That is called mitral regurgitation. So the common causes of leaking of this valve, where the blood moves to the left atrium instead of the left ventricle pumping blood into the aorta, happens in younger patients most often due to mitral valve prolapse, which is you're born with a very floppy, thick myxomatous valve that is just a genetic cause for how you're born with. But then we see the patients that I am commonly seeing in my practice are patients in the 70s and 80s, where there is degeneration of this valve that has happened due to a couple of reasons. Either patients, unfortunately, have had heart attacks where the heart muscle is damaged, so the valve is now not closing well, because the valve is being pulled apart by the pumping chamber, and that's causing mitral regurgitation. There are some patients where the leaflets, like every other part of the body, gets weaker, and the leaflets are held down into the heart by what are called chordae, or which are like threads that hold the valve down. So as part of aging, some patients have a rupture of the chordae. These threads break, and then the valve is not competent anymore, and then suddenly they can have a significant leak, causes mitral regurgitation. And there is an increased recognition lately that patients who also have atrial fibrillation, which is a common abnormal rhythm of getting older, 10% of us will have it when we are in our 80s. Atrial fibrillation, when present for a long time, can also predispose to mitral regurgitation. So these are the common reasons.
Mhm.
Genetic in the younger patients, heart attacks, atrial fibrillation or just degeneration due to aging in the older patients.
Sure. So, Jyoti, I know you probably don't see a lot of rheumatic heart fever as a cause of mitral regurgitation, but I know in other countries, such as sub-Saharan countries, it is very common, especially in children, as a cause of MR. Is that right?
That's right. That's so when you look at the worldwide etiology for mitral valve disease, rheumatic heart disease is still there because most of the population lives in parts of the world where rheumatic heart disease is still prevalent. So, like you said, sub-Saharan Africa, many parts in Asia, some countries in South America, Central and South America, rheumatic heart disease that manifests in young children that causes inflammation, scarring of the mitral valve is still the most common cause for mitral valve problems. Many of those patients, when the valve scars down, eventually will present with mitral stenosis. So it kind of scars down, thickens the valve, calcifies it, and makes the valve very narrow. And patients are presenting with shortness of breath and so forth because the valve is too narrow. But there are subgroup of those patients where the valve is so damaged that it does not close too well and can cause a leaking valve. But in the US and in the Western hemisphere, rheumatic heart fever as the cause of mitral valve disease or regurgitation is not very common. We do see an occasional case, but not very common.
Right. Yeah, it's just very unfortunate because, group A strep is a very simple thing to treat. Like you said, your father was using penicillin when you were a child, and you've kinda come full circle because your dad unknowingly was probably treating, rheumatic fever with penicillin.
Yeah. No, that's very interesting because it so happens that my mom, who has passed away about 7 years ago, she had rheumatic fever as a child and did have some scarring of her mitral valve. Luckily, not bad enough that through the course of her life she never needed. But as she got older and sicker with other comorbidities related to diabetes, this valve issue did come up as an issue that was complicating taking care of her and volume status and so forth. So, yeah, it is kind of now that you mention it, it is coming full circle.
Right, right. So, Jyoti, is there a, gender preference for mitral regurgitation in the United States?
So the mitral valve abnormality, so now the based on my description before, the when you read the literature or see it, mitral regurgitation is divided into two big groups. Primary mitral regurgitation, meaning patients whose valve is very abnormal, and secondary mitral regurgitation, where the leaking valve is secondary to some other problem in the heart. So, when you look at primary mitral regurgitation, where the valve is a problem, these are usually floppy valves, prolapsing valves. The gender, it is more in women than in men and presents at a earlier age than later. When you look at secondary mitral regurgitation, where the valve is a bystander, the problem is either with the ventricle or the atrium, like I said, causing a heart attack or atrial fibrillation causing due to regurgitation. That tends to be more in men than in women and presents at a much later age in life. So there is a very interesting dichotomy of what genders are affected based on which of the two mechanisms cause mitral regurgitation.
I see. Very interesting. Going back to mitral valve prolapse, so does everyone that has mitral valve prolapse develop MR?
Actually, not. We do see a lot of patients, and some of you who are listening to this may have been told by your internist cardiologist that you have mitral valve prolapse, and that was a diagnosis historically made purely by your physician on auscultation. And it looks like there was an overdiagnosis because people were hearing clicks and the prolapse was not actually significant. So now the mitral valve prolapse is an echocardiographic diagnosis. The valve has to have a certain thickness, certain floppiness, and a certain amount of prolapse to call it mitral valve prolapse. Most of the patients, and it is quite common, 2% of us will have mitral valve prolapse, but most patients go through their life without the valve eventually leaking bad enough that it presents a problem with shortness of breath or heart failure or atrial fibrillation or pulmonary hypertension, some of which we'll get into, needing an intervention to fix the valve to stop the leak or decrease the leak to prevent progression of it. So you look at the whole population, 2% of us have mitral valve prolapse, but it's only uh, uh, about 5% of that entire population who will need a procedure in their lifetime. And the likelihood of progressing is based on how abnormal the valve is and how much of prolapse there is. So when we see patients with a lot of prolapse and a very abnormal valve, it's likely that at some point in their life that valve is going to start causing significant enough leak to be of clinical relevance.
Got it. Okay. And this is a common question you probably get, but does everyone with mitral valve prolapse need to take antibiotics before going to the dentist?
Yeah, that's a very useful and interesting question because 15 years ago, that was the practice. Anyone who had a diagnosis of mitral valve prolapse, the recommendation was that their valve was at a higher risk of attracting any bugs that were circulating in the bloodstream, which is common after deep dental cleaning or any other procedures where there is potential for bacteria, like any procedures involving the urinary bladder, colon, any of those procedures. If there were to seed the blood with bacteria, the concern was that it could attach to a very abnormal floppy looking valve. But looking back at the incidence of endocarditis, infection of the heart valve, they found that the incidence was very, very, very low. In fact, the likelihood of antibiotic related side effects and antibiotic related resistance and antibiotic related anaphylaxis was much more common. So the ACCHA, the College of Cardiology and the Heart Association, changed the guidelines, I think now about 8 to 10 years ago, saying that just having mitral valve prolapse with mitral regurgitation was not an indication to take antibiotic prophylaxis during a dental visit anymore. The specific subgroup who still needs it is number one, if a patient has had a prior bout of endocarditis infection on the heart valve, that this is a subgroup that has declared itself to be at higher risk. So those patients do need to take antibiotic prophylaxis. If the patient has had a surgery on the valve, they had a repair or a replacement, or then these are patients who definitely need to. So these are the subgroups who need prophylaxis, but most of the others don't.
That makes sense. Thank you. When a patient has clinically significant mitral regurgitation, what are the usual symptoms they might have?
So, as you can imagine, when the left ventricle squeezes blood and most of the blood that is supposed to go forward, there's a good percentage of it going backwards into the left atrium, which is the chamber into which the lungs are emptying good or oxygenated blood to. So the left atrium is a chamber that's directly connected to the lungs. So you can imagine if there's a lot of blood leaking back into the left atrium, this blood is causing increased pressure into the blood vessels of the lung. So patients usually complain of shortness of breath because there is higher pressures and potentially even fluid backing up into the lungs. Because there is less blood going forward to supply blood to your body, patients complain of fatigue, tiredness, exercise intolerance. Because you can imagine if there's 100 ml of blood that your heart was supposed to squeeze, and all 100 ml, instead of going forward, 50 ml is going backwards, there's less blood to go to the rest of your body to clean up, to flush your muscles, to flush your kidneys. So, fatigue, exercise intolerance, shortness of breath are usually the early manifestations of clinically significant mitral regurgitation. And with time, as you can imagine, when the atrium is exposed to all this blood and the atrium starts to get dilated, patients are at higher risk of developing atrial fibrillation, an abnormal rhythm of the heart. Patients are at risk of developing pulmonary hypertension because, like I said, the blood is backing up into the blood vessels of the lung. So pressures within those blood vessels can go up and cause pulmonary hypertension. So these are the long-standing consequences. The immediate consequences are usually exercise intolerance and shortness of breath.
And this is where you would come in and diagnosis using an echo, correct?
Exactly. So the patient's symptoms are key to helping make a decision about when to intervene, because we do have many patients who have had moderate amount of leak that we are following along, and it is when either the patients have symptoms related to this mitral regurgitation, or there is imaging findings specifically with echocardiogram that is showing signs that the heart is now no longer compensating for this extra volume that it is handling. It is starting to show signs of stress. And the signs of stress would be either the heart chamber starting to get enlarged, the pumping function of the heart slowly starting to get weaker, because as you can imagine, like I said, 50 ml, if a heart squeezes blood, 50 ml is going in the wrong direction. The heart has to accommodate that extra leaked blood for the next beat. And over a course of time, the heart starts to get larger, and a larger heart over course of time will get weaker. So
Mhm.
we use echo as the best non-invasive way to sequentially follow patients. And with each time we do an echo, we are looking for, is the heart getting larger? What is the volume increase? Is the atrium getting larger? Is there a change in the pulmonary pressures? All of these are incorporated along with the patient's symptoms to decide on the timing of an intervention.
I see. Is there any indication to do a transesophageal echo versus a regular echo in these patients?
Many of these patients do end up getting a transesophageal echo. That is for two, three reasons. And number one is when there are, as you can imagine, it is a smiley shaped valve. So if there are leaks that are happening right at the corners, transthoracic echo, we call it an eccentric jet, meaning that the jet is kind of at a very margin of the valve and is really hugging the atrium. So you could potentially underestimate the true severity of the leak. So, transesophageal echocardiogram, because the echo probe is sitting in your foot pipe right behind the left atrium. So, the best valve to be seen by transesophageal echo is the mitral valve. And these days, with a lot of additional technology with 3D and so forth, the fidelity and the quality of images that we get that enable us to exactly identify the lesion that's causing the MR, to be able to quantify the MR is all better by TE. But not everyone needs a TE. If patients are being conservatively followed, we use transthoracic echo for follow-up. The other reason to do a transesophageal echo is to help make a decision if this is a valve that can be treated by surgery with the repair, or does it need a replacement? Or in some of the patients, like I mentioned, who are elderly and maybe too high risk to have surgery, there are some newer options to treat these patients by catheter based therapies. So then the transesophageal echo becomes very, very important, because a lot of the decisions about, is this a good candidate for non surgical repair? Will we get enough of a reduction? Are there obvious contraindications or limitations that preclude us from being able to do? So those kind of decisions can only be made with the data that we can obtain from a good quality transesophageal echo.
Great, great. Well, sort of leading into the next question, what are some of the current treatment options in patients who have severe MR?
So, in patients who have an abnormal mitral valve, which is primary mitral regurgitation, the gold standard of care is mitral valve surgery. And these are patients who are otherwise not considered to be high risk for undergoing a surgery. And the gold standard of surgery in the Western world is a mitral valve repair. What I mean by that is the surgeon goes in, they remove the excessive floppy tissue of the valve, they remodel the valve, they put a ring around the valve to make the annulus, if you may, the circumference of the valve tighter. The beauty of this procedure, when done by very skilled surgeons, is that you are leaving the patient's valve behind, meaning that there is no longevity issues related to it because it's a patient's own valve. So the hope is that with a good repair, that is the only repair that the patient will need. But the practice across the world and even in places that don't have the expertise to repair the valve, the surgeons will replace it. And when they replace it, they are removing the existing valve and putting in a bioprosthetic or a mechanical valve in its place. That comes with its own set of problems that the valves that are put in, if it's a mechanical, it needs a blood thinner for life. If it's a bioprosthetic or a tissue valve, that comes with the lifespan. And the lifespan of the valve depends on how old the patient is. If it's a patient younger than 55 or so, it may last only 10 years. If a patient is 60 years or older and gets a bioprosthetic, it will hopefully last 15 years. So, whenever you're looking at a valve replacement, you're always in the back of your mind as the cardiologist and the treating physician thinking of, is this patient going to be a candidate for another surgery in 10 years or 15 years? So that's the reason why repair has become more prominent. The cardiac surgeons these days are all coming out very well trained in being able to repair these valves.
And the surgery is still done by the open heart technique, correct?
Yeah, till recently, you had to do a full sternotomy, open up the atrium, look at the valve, remove this excessive tissue, then put a band, then take stitches all around the annulus and tighten the band. But we are lucky that we have one surgeon here who does robotic mitral valve repairs. So he's doing it using the Da Vinci robot with this ports where he is able to again access it without a sternotomy and do the repairs. But it is not all patients who are eligible for a robotic repair. Most of the patients, again, there is not enough robotically trained surgeons across the country. For most patients in the country who need this valve repaired, it's being done in the traditional approach by a sternotomy. But definitely for those patients who are looking at needing a procedure, they definitely want to access what we call centers of excellence, where there is a surgeon who has enough experience, who's doing more than 30 to 40 of these repairs a year, because it is a very specific skill set that not very, so in a center like ours where we have 7 or 8 surgeons, it is only 2 surgeons who are doing mitral valve repair. So it is a very art and science combined together where you really want to shop around and make sure that you're going to a surgeon who does have a lot of experience with repairing a valve before they decide that it needs replacement if the valve cannot be repaired.
Great. Thank you, Jyothi, for sharing that. Jyothi, what is this newer technique called transcatheter edge-to-edge repair, or TEER?
Yeah, so thanks for asking that. It is interesting that when you looked at the population of patients who have severe mitral regurgitation, what was seen maybe about 20 years ago is that it's less than 4 or 5% of the patients with severe mitral regurgitation who are candidates for surgery. So, like I said, bulk of the patients who are coming to attention are in their 70s, 80s, usually with other comorbidities. They have had a prior heart attack, they are in heart failure, they have lung issues and kidney issues, prior strokes. So most of the patients who had severe MR who are older were not thought to be surgical candidates by the surgeons and hence denied surgery. And the natural progression of mitral regurgitation was that the heart would get weaker, patients would end up in heart failure or AFib or a stroke, and there was really not any medical options to treat these patients. So about 20 years ago, some researchers, and it's very interesting that most of this work happened in Chicago and in combination with a company in Israel, where they saw that there was a surgical technique called Alfieri repair. It's named after a surgeon where he would put a stitch at the center of the valve and make a single orifice valve into a 2 orifice valve. So if you may, he would take like a fish mouth and put 2 stitches in the center, and now there are 2 holes on either side with the center. So the investigators and the engineers and the cardiologists who are interested in this were trying to reproduce the surgical approach of an Alfieri using a stapler kind of device where they envisioned that they would go across the interatrial septum and go under the valve and try to capture both leaflets of the valve into this device and then close the device on itself, almost like a stapling gun, and reproduce the effect that the surgeons used to have in the operating room. And so, kind of, there were early trials, and the goal eventually in their mind and the vision was that for this large group of patients who are not considered surgical candidates, can we offer an approach by a catheter, which is less invasive, done with maybe an hour and a half, 2 hours of general anesthesia in the cath lab instead of in the operating room? And that kind of led to this transcatheter edge to edge repair technique, modified from the surgical approach to using a device to bring the two parts of the leaflet together. So, very interesting.
That's very interesting, yeah, and you mentioned the axis is going from the right side of the heart to the left
Yeah.
atrium, correct?
So that is the other beauty of this, is that it is a femoral vein access. So the interventional cardiologist and the surgeon, who are part of the team, access the femoral vein. They go through the inferior vena cava. They reach into the right atrium, and using a needle, these days it's called a radiofrequency application, to cross the septum. So they do a transseptal puncture at the level of the fossa ovalis, which is the thin part of the septum between the left and the right atrium. And they come across to the left atrium with what we call a guide. And this device is within the guide. So the guide is then positioned in the left atrium. And my role as an echocardiographer, interventional echocardiographer, is to provide all the images that the interventionalist or the surgeon needs. Number one, to be able to cross the septum safely and to cross at a spot that gives them enough height, if you may, to be able to maneuver this device and the catheters and so forth. And number two, once they cross the septum into the left atrium, then rest of the procedure is being guided under echocardiography. So we are guiding them to where they should position the device. We are guiding them to how the arms of this device should be oriented. We are guiding them to, is there enough of the leaflet that is captured within the device? We are guiding them to how much of a reduction did we get, and so forth. So it's a very interesting for me to be a non-invasive cardiologist and be very involved in such an invasive procedure and have a significant contribution to the patient's care.
That's very, very interesting. Jyoti, this is kind of a silly question, but why access the femoral vein? Why not do the femoral arterial approach?
I think, as many in the audience may be, so that is the approach for the transcatheter aortic valve replacement. So these days we are familiar with many of our patients who are opting for a transcatheter aortic valve replacement. So there you go across through the femoral artery, cross the aortic valve, and then you're deploying the new catheter-based valve there. But as you can imagine, with the way the heart is shaped, to you would have to first cross the aortic valve, and you'll have to cross the aortic valve with the guide and the catheter and the device in place. And then positionally, you are directly positioned below the valve. So it's very hard to be able to navigate and get your device in position from within the ventricle. Because whenever, as you can imagine, for those of you who have the image of the heart in mind, when you pull that catheter back, it's all coming back into the aorta. It's not coming back and capturing the mitral valve. So that's the beauty of this procedure, is that it is a venous stick. And as many of you have experienced with venous sticks, you apply pressure for 10, 15 minutes and it's done. This is obviously a larger bore catheter. So at the end of the procedure, they do what they call a figure 8 stitch. So they do a number 8 figure and close the site of access. So the risk of kind of bleeding, local hematoma, all of that is much less when you're accessing the femoral vein. So this is not an option to do it through the femoral artery crossing the aortic valve.
I see. Thanks for clarifying that, Jyoti. What are the risks involved in this technology, and what have the studies shown so far regarding the results of this?
Thanks for the question. The first group of patients that were studied were primary MR patients who have these very floppy valves, and that is the group of patients who are considered high risk for surgery. These are the patients that is now approved by the FDA and the CMS, the Center for Medicare. And as you can imagine, most of these are older patients who are under Medicare. So these are the patients where who are not candidates for surgery or considered high risk who were studied in the trials. And what they showed was that the results were comparable to surgery with immediate, again, you're taking away the most patients are going home the following day. So you're taking away the ICU stay, the length of stay in the hospital, the risk of renal failure, the risk of stroke associated with surgery, and so forth. But you're trading for the fact that there is a device and a catheter going into the left side or the systemic circulation. So patients are getting blood thinners during the procedure to prevent any clots from forming on any of these part of the device. So there is a small risk of stroke if there is any clot that happens to form on the catheter or the guide or the device. You are going through a larger caliber catheter, so there is risk of vascular injury. And again, like I mentioned, because it's a femoral vein, the injury is much more benign, if you may. And the biggest risk is of the risk of the device not completely deploying. If luckily, the studies have shown that there is a learning curve to this procedure for the interventionalist. The risk of the device, it's called a single leaflet attachment, and that happens in about 2 to 3% of the patients in many of the studies. What happens is as an echocardiographer, it is my role and my team's role to make sure that we tell the interventionalist that we have confidently captured all the leaflet into the device. And sometimes, if we are all of us are confident, but we close the device, and it so happens that one of the leaflets has not been inserted deep enough, and if part of it is inserted but not deep enough and it slips out, now you have a device that is at risk of embolizing or is attached only to one leaflet. So you're left with all the leak without having treated the lesion, and now you have a second kind of risk. Again, it's a very small percentage, but that is a risk you have to be aware of, which is why the transesophageal echocardiogram that is used for pre-planning, we spend a lot of time looking at the leaflet length and the height, and is this a good patient for a transcatheter edge-to-edge repair. These are the things that are being kind of discussed as we are talking between the non-invasive guys, the interventional guys, and the surgeons to say, is this a good patient or not? So these are the risks associated with it.
Great, great. Thank you, Jyothi. You mentioned the stroke risk. Now, post-procedure, do these patients require anticoagulation?
Yeah, the device, there are two devices that have been approved by the FDA, are both made of nitinol with a layer of fabric around it. These devices are at risk of clot forming on the device. And just like a stent or other procedures, the recommendation is 6 months of some combination of either a dual antiplatelet agent with aspirin and Plavix, or many of these older patients that we are seeing are already have a diagnosis of atrial fibrillation or are already on a blood thinner with Coumadin or Eliquis or Xarelto or something similar. So if they are already on a blood thinner, we just continue the same. We don't add like a Plavix in addition to it. But if they are not on any blood thinners, then 6 month duration of dual antiplatelet therapy is recommended. By then, the device is formed endothelium around it and it is scarred up, and so it's no longer at risk for any thrombus forming on the device.
Got it. Okay. And Jyothi, what do you see in the future in this field for the management of mitral regurgitation?
I think what the newer studies have shown is that two, three things which are very interesting. Number one is patients who have had history of a heart attack and heart failure with the weak heart muscle but have heart failure related to mitral regurgitation. These are the best patients who can benefit from a non-surgical approach to reduce mitral regurgitation, because if there is a very good study that was done about 4 or 5 years ago called COAPT, COAPT, and that study showed that in patients with weak heart muscle with significant mitral regurgitation, this procedure, along with all the medications for heart failure, can not only prevent them from getting admitted to the hospital with heart failure, but can actually prolong lives. So, this is a subgroup where we feel that there is a great non surgical approach to help to defray some of the symptoms that happen as the patients get sicker. Where the field is moving is that currently, as I mentioned, it's approved in patients who are considered high risk for surgery. At Northwestern, we are part of a trial called Repair MR, where patients who are not high risk, who are intermediate risk, patients with lower surgical risk, are being randomized 1 to 1 to either surgery or this procedure with the mitral clip. So, if you are a 70-year-old patient and you are considered to be eligible for the study, and you're willing to take a 50% chance that you could get operated by Dr. McCarthy, the main surgeon of the study, or undergo a mitral clip, then that study, I think, will change. And if that study, we think, if it shows that this procedure is non-inferior to a surgical approach to treating, then suddenly there will be more patients who are eligible for a non-surgical catheter-based treatment of their mitral regurgitation. There is an NIH study looking at even lower risk patient called primary MR to see if how it compares to surgery, but that study has very slow enrollment and will take many more years for an answer to be clear in that. So I think that is on one side. On the other side, we now have accumulating data that the experience matters. There is a learning curve to this. 30 to 40 procedures seems to be the learning curve at which the entire team has the capability to successfully do these procedures with the most lowest possible risk. So not only the interventionalist, but the imager like me, the other members in the team have to all be experienced enough and have had 40 cases under their belt or more to be able to get consistently reproducible, successful result with these patients. And the last thing before I close is that what the newer data has shown is that this actually has improved, kind of in a very paradoxical way, has improved the surgical outcomes of patients who are undergoing mitral valve repair. And it's kind of very interesting because what happens in many of the centers, including ours, is that when these very high risk patients who need a mitral valve surgery come to our attention, the surgeons would first ask the interventionalist and us to review the patient and see if they are eligible for a non surgical catheter based approach. So the surgeons are actually operating on patients who are slightly lower risk, which ends up that they have better outcomes with low risk. So it's kind of not only changing the field of interventional cardiology, and but it is actually lowering the risk of the cohort of patients coming into the operating room for surgery. So it's very interesting.
That's very exciting. Very exciting. And
Yeah.
looks like you guys have a great team over there at Northwestern as well.
Yeah, I think it's a privilege that I kind of landed up here, and then I kind of got right into this, I think, into this whole transcatheter based field that had a need for a lot of imaging time. So it is a lot of time commitment, but it is very satisfying, and it's kind of great to be part of a team where all of us are contributing our own expertise, whether it's a proceduralist or the imager or the anesthesiologist or the technician assisting or the research coordinator who's getting these patients through the door and following them through. So it's kind of you really need a team to have a successful program for this transcatheter based therapies. You cannot have a single operator kind of really take it to the success. So I'm kind of very happy, privileged to be kind of here and be part of this team here.
Yeah, it's almost like non-invasive cardiology has become invasive.
Yeah. Yeah. So then I think when they gave me this title 5, 6 years ago, and I would kind of put it on the talk, and they would be like, "What are you doing? A director of interventional echo? What does that mean?" So then obviously now it's changed where every year we are training 4 fellows, and these are fellows who have finished cardiology fellowship and are dedicating 2 years of their life to come and train with us to do 1 full year of just what we call structural or interventional echo supporting these cases. And then they go on to spend a year in CT and MRI. So these fellows are coming out as what we call advanced cardiovascular imaging fellowship. So 10 years down the line, we are going to have a whole set of very well trained cardiologists who have all the expertise and skills from an imaging perspective to really identify the right patient for the right therapy and to guide them intra and post procedurally to getting more success. So the field is kind of very ripe, and it's kind of very exciting to be involved in training some of these fellows who are going to be the next generation of leaders kind of in different parts of the country and the world. So it's kind of very exciting.
Very exciting, Jyothi. How do you, as a trainer, continue to learn and stay up to date in this field?
So I think it's a two-way street, meaning that the fellows who are coming to do this fellowship have already finished 3 or 4 years of cardiology training. So they are kind of really at the edge of they have all this knowledge, but they've not started to practice. So they are really putting us on our toes to make sure that we are fully up to date and kind of being aware of every new trial and every new device that is coming into the market. Until I got into this arena of structural or catheter based procedures, I really had very little contact with the industry because what I did as a general cardiologist involves very little. I have some connections with ultrasound companies and so forth. But now I'm completely interacting with the whole different set of industry partners who are biomedical engineers, marketing people, and these companies that make these devices. And it's a two-way street. They need kind of our input as to how to fine tune and make these devices better and how to image it better and so forth. And we get a lot more than they get out of us in terms of how did they design this piece of the catheter and what was the iteration they made with the second time. So it's a very interesting part where having this relationship with industry instead of seeing it as a conflict of interest, in fact, is very educational for us and our fellows to say this is the next development that they're looking at that will make this procedure even more consistent and reproducible. So it's been very good. And then in an indirect way, because we were at the earlier set of hospitals and lucky to be in the earlier set of investigators who got access to these devices and got to kind of work with them, we are now being called on to train the next generation of people who are going on to do these procedures. So when you suddenly assume a training hat, it kind of forces you to have another skill set because you're training people who've been doing procedures for 10, 20 years, but then you're giving them a new skill set. So there is a lot of knowledge that they have from their practice, but you have some unique knowledge that you kind of disperse to them. So this kind of involvement with industry is very new, being a non-invasive cardiologist, but it's been very beneficial to have this perspective and to kind of make the whole pie complete, if you may.
Got it. Great. Jyothi, changing topics, so what are some of your interests outside the hospital? For example, how do you like to decompress?
I kind of, luckily for me, maybe kind of since I was in school, I was kind of actually forced to run because I was overweight when I was a kid. But I think, like we tell, whatever we did when we were in our middle school, high school years, college years is what we are going to kind of continue for life as our kind of lifelong habits. So I enjoy running, but as I get older, I realize that it takes me, especially living in Chicago, there is a few months of the year when you cannot absolutely run outside. So you really have to modify your kind of exercise routine. So exercise gives me some of the decompression that I need. I used to play squash regularly till COVID. And as you can imagine, with the squash courts, they are like prime territory for COVID to spread to each other. So I am kind of looking to go back to playing squash now. In the summer, I enjoy biking, and since we live in Chicago and there's a beautiful bike path, I kind of enjoy riding up and down as much as possible. And I'm an older parent, but I'm fortunate that I kind of have two young kids, 12 and 7, who again, like my fellows, keep me on my toes. but kind of the main decompression that I have outside of work. So then I really enjoy reading. When I can, I try to kind of get in some amount of reading, and the reading has obviously changed over time from fiction to nonfiction to philosophy to other things. So it's been, is other thing.
Great, great. Yeah. What's the longest bike ride you've ever done?
So I used to, with a couple of other friends, we would do this. There is a Respiratory Health Association fundraiser every year in August up in Wisconsin that starts in Gurnee and goes to Lake Geneva and ends in close to Milwaukee. And they break it up over 2.5 days. And the second day, the first day is 70 miles, the second day is 100 miles, and the third day is again 70 miles. And that second day of 100 mile in one single day, that's probably the longest that I've done. And I'm kind of, now that the kids are a little older, I'm hoping that I can kind of go back to some of these amazing rides that we have access to living in the Midwest. There are beautiful paths in Wisconsin and Indiana and Iowa and all this multi-day fundraising kind of rides that we have access to, that kind of I really hope to get more engaged with as the kids get a little older, and then I can be away for 2-3 days to do this.
That's impressive. More power to you.
Just
So, Jyothi, I just want to thank you for clearly simplifying things for us and explaining, what mitral valve regurgitation is, and talking to us about this exciting transcatheter edge-to-edge repair technology. Thank you so much again, Jyothi, for your time and being a guest on MD Roundtable. Keep doing the great work you do, and I really appreciate you being on the podcast.
Thanks a lot, Ted. Hope the audience gets something out of this, and then kind of looking forward to engaging with you again in the future on future episodes. Thanks for this opportunity.
Definitely. Thank you. Have a great day.
Thanks a lot.
Folks, if you enjoyed that episode, don't forget to leave a review of MD Roundtable Podcast, and don't forget to subscribe. Also, if you want to reach out to me with any comments or questions, feel free to go ahead and email me at drtedthatchandcarey@gmail.com. Once again, drtedthatchandcarey@gmail.com. I will also leave the email contact in my show notes. Thank you again for joining me. Have a great day.